So Julie, you can start.
Hi, everybody. This is Julie from New Jama. Thank you for registering for our webinar Wednesday, where we're trying to get our members more information and keep up educationally on activities and programs provided by our vendor groups. So today we have Comply Assist. Their webinars like how to be ready to pass a surprise COVID-19 audit. So our presenters are Jerry Blass, who is the CEO for Comply Assistant, and we have Dana Penny, Chief Compliance Officer at the New Jewish Home out of New York. Welcome.
Okay, thanks, Julie. So this is Jerry. Dana will be speaking in a minute or two. I just wanted to go over a couple of things. So we have the objective, and in looking at the objective, we're hoping, to make this an interactive discussion. So I'll talk about that as well in a second. But you can see how Dana is going to provide insight into how you can be ready to provide an excellent documentation around an assessment and a response plan in relation to COVID/pandemic, and to focus on ways to organize in order to be ready. And then, one of the things we'll talk about is there are a number of guidance checklists. You have CDC, World Health, HHS. Some organizations use CDC. Dana at the New Jewish Home use CMS. He'll talk about that. But there's a number of guidance that is already available. And if there's others that we need to look into, we can do that, and we can talk about that. So let me just go back to here. Administrative, this is looking to run somewhere around 45 minutes, but we can go longer. The PDF that you're seeing today and the link to the recording will be available to everybody. All attendees are on mute. But as far as questions go, you can either type questions into the question panel, and we'll deal with those at the end when Dana is finished with this presentation. Or if you'd like to raise the electronic hand on your panel, if you can see the icon that shows the hand, if you want to ask a question interactively while Dana is presenting, just click on that. I will unmute you, and you can ask your question. Okay, so let me just do this. So the case study that we're going to cover today is, again, the surprise audit that Dana and his team at the New Jewish Home, experienced at one of their locations. They have 2 locations, and he'll talk about that. It was right in the middle of when the Northeast, New York, and especially nursing homes in New York City were really hit hard. And I guess that was part of the motivation for the DOH, Department of Health audit. Dana will discuss the makeup of his team, everybody that worked together during that time frame, and I guess still working together. And he'll also discuss some of the different options on tools. And so with that, I'm displaying Dana's bio and his picture, so you can see. You can read the bio, but most importantly, I'm going to turn it over to Dana. So give all your attention to Dana at this time. Thank you.
Well, good morning. Thank you, Jerry. Thank you, Joy. My name is Dana Penny, as Jerry just mentioned. I've been working at the New Jewish Home for the last 20 years, and I think that we've got a tremendous team here. We want to talk about the circumstances of the survey, and we use audit and survey sometimes interchangeably, but in this particular case, I'll be using survey and assessment because there's 2 different elements to this. As everybody knows, and New Jersey was hit just as hard as New York, particularly northern New Jersey. We had as the pandemic grew and there were more cases of illness across the city and across the state, there was a real drive to make sure that the healthcare facilities we're prepared, or at least in a good reactive mode. Now, we're supposed to have an emergency preparedness plan in effect, and most people did. We certainly did. What we didn't have was a pandemic emergency plan, which is now a requirement in both New York and New Jersey for all healthcare facilities. So we need to be prepared. We need to be prepared for a resurgence of cases that may occur. We need to be, one of the lessons learned from the hardest time that the states have gone through here, is that if there's another pathogen out there, whether it be a severe flu or, God forbid, some other new pandemic potential pathogen going around, then we need to be prepared for that. When all this started happening, there was guidance that came out from CMS and from the New York State DOH and the CDC on how nursing homes and other healthcare facilities need to be prepared. So I believe it was April, in the middle of April, I think it was the 16th or thereabouts, CMS published and announced that they would be doing special focused infection control surveys of all nursing homes across the country. And particularly in New York and New Jersey, they were going to start because we were amongst the hardest hit by mid-April. They were kind enough to provide us all with the protocol that they were going to give to the state surveyors who were going to be coming, who would either visit you on site or ask for all kinds of documentation relating to those survey questions as their survey. So we were required to complete this self-assessment, using the surveyor's protocol, and then be prepared to hand it over, or be prepared to answer when they came in the door, just along the exact same lines as the assessment. So what we did was we had our emergency preparedness team, or our COVID-19 team, which was made up of the facility administrators, program directors, nursing directors, the medical staff leadership, as well as executive leadership and HR, IT, quality improvement, compliance and legal, and as well as other folks in charge with procurement and in facility management. So we had quite a diverse team from the beginning, which was really important because everybody had a stake in what's going on. So all the stakeholders may not necessarily always be in daily interaction with each other, but it was good to have them together. We had a daily call every day, 7 days a week, at 12 o'clock with this group to let us know how we were doing as far as how much supplies we had on hand, what the clinical status is, and any particular issues might be arranged at any of the buildings or in the programs. So when this guidance came out from CMS, I looked at it and said, okay, well, it's a checklist, but there's a whole lot of sub things under each check. And how are we going to make sure that we have the evidence and documentation that we need? Because they were asking for many, many different things, policies and procedures, and a variety of items. Evidence of training, evidence of audits, what kind of signage do you have? Do you have a sign on everybody's, anybody who is on high precautions? Do you have a sign on the door? That sort of thing. And we have been following along with the guidance provided by the CDC, and a lot of these things matched up, so that was good. But when I tried to make a good checklist that we could use for a self-assessment, since we had to turn it over, I was a little stymied. I did turn to Jerry and his group to Comply Assistant. They were able to put the questionnaire along with sub questions into their software, and we were able to use that to prepare so that we could say, okay, immediately it became apparent that we didn't have all the updated policies. We had plenty of infection control policies, but they didn't mention COVID-19. So we had to scramble and make sure that those policies were all ready and were focused on COVID-19, had new addendums on them for that. And we had to look at our policies and procedures regarding personal protective equipment and how it's used, what you do to conserve it, because there were obviously shortages by the middle of April. Everybody was scrambling to get it. How did we do staff screening? What the housekeeping procedures were? How often were they cleaning common areas? What were they doing in the residents' rooms? And then we had to have, we realized we needed staffing protocols, the staffing policies, I guess, to say, all right, we've, what do we do when we have, when people are out, either because they got sick, which some of them did, or they have a member of their family who's sick, and they had to quarantine themselves and they couldn't come to work. And then there were staff members who were just didn't want to come in because of fear. So we had to make sure that we really scrambled to get additional staff on site and in the pipeline so that they could be put on site. And then all those folks had to be trained in infection control and the orientation, the usual types of things when they're new personnel. We had to be able to show all of these things. And so the lesson learned here is be prepared with a self-assessment. The irony is that as we were preparing, because we knew that they were going to come in at some point, most likely, because we did have, unfortunately, a rather high incidence of COVID-19 in our buildings. And what we did was prepare ourselves by using this tool and making sure we had audits and improved on the audits, that kind of thing. And, of our own self-assessment of what we're doing. And we had done in one building in Manhattan, we had done, which is a 500-bed nursing home, we did a mock survey as if we had a team that acted as they were the state inspectors, and we did that, and we learned a lot from that, and then we proceeded to go to our Westchester nursing home, which is a 300-bed nursing home in Mamaroneck. While we were preparing to do the on-site, we were on site, our team was on site to do our own mock survey to see how well the staff there were prepared. We had already collected all the documentation, all the different policies and things like that, and just the way a state surveyor would do. While we were preparing to go out and fan out across the facility, in walk the real surveyors. So it was a surprise, not wholly unexpected, but always expected the unexpected because it will happen. Sure enough, they came in and they asked for exactly everything that we had already prepared. So we were very well prepared for that. In both cases, and we were able to, with some slight exceptions, but we didn't get any deficiencies for them. We still had our communication plan needed some work still, but we did very well with the survey, so that was great because we were prepared, because we had a interdisciplinary team working on that preparedness and checking up to make sure that people were getting the education they needed, that they were getting the personal protective equipment that they needed, and that the staffing was sufficient to take care of the residents that we had. And then the next week, they popped into the Manhattan facility as well. So we were prepared, and in both instances, the infection control surveys went very well. You've even had a third one that came back. So I think the lesson here is be prepared, be very prepared. Do your own self-assessments and really look at yourself with the jaundiced eye of an outsider. When you look at the questions and you look at the documents you have, you got to really look at them and say, is this good enough? Is this reflecting what we actually do? Is this aspirational or is this real? And check against it, because you could have the most, sophisticated policy that says you're going to do all these things, but if you go on the ground and ask people, they don't never heard of the policy, or they don't know what kind of cleaning solution you're talking about. They have no idea what's in their hands. They have no idea what kind of mask they're wearing. All those kind of things are going to count against you. So it's very important that you do a self-assessment in order to be prepared. I mean, that's what we learned, and it really got us much along the way. And I think in the end, implementing all these items, all these policies, all these activities, that we provided better patient care. So that's our story as a case study. But I think one of the things for the job group here, we need to, we look at, you guys are not a nursing facility. You may not have the same set of guidances, very precise guidances that we received that enabled us to, follow a pathway. But every healthcare facility is going to get some kind of, audit or inspection going on. And I think that it's important that everybody be prepared and that they have a process in place. Of course, that starts with having that response team. Who is on that team? Who are the stakeholders? Does the leadership of that team have a background in infection control? You really need that. If you don't have somebody locally in your agency or your in your building, especially for residential facilities, you need to see who else in your agency can apply those infection control principles to that building sooner than later. Now, I'm sure most of you have already done this kind of work. And now is the time to be able to look back and reflect and say, okay, did we do a good job? Do people really understand what we have? Because if you haven't had any kind of, survey or audit or assessment done by outside members, it will probably come. And whether it's going to be the state health authorities or the state substance abuse and developmental disabilities authorities, those folks are, they may contract with somebody, or the state may contract with somebody, or SAMHSA might tell everybody they've got to do, this is what they've got to do. And looking at that, even when we went to the websites, looking at what is happening in your particular area of healthcare, we did find guidance from SAMHSA regarding state hospitals, state psychiatric hospitals. And I think it's worth everybody to go find that guidance and familiarize yourself with it and see, okay, this is from the federal level, this is what we should have. And even though you may or may not be a psychiatric hospital, the same principles will apply. And that those principles are, education, supplies, processes, care planning, and how to maintain social distances amongst your residents, how to maintain, making sure that they're washing their hands and they are wearing a mask. all these types of things that have to do with care, and whether you've got a plan in place, particularly for any residents and patients who may, delusions, or I'm afraid I'm not familiar with all the up-to-date phrases used in mental health these days, but just bear in mind that some people are not going to wear a mask, and I'm sure you've experienced this. They don't want to wear a mask. They've got all kinds of arguments. They don't want to stay in their room, that kind of thing. And we certainly have the same exact issues with our dementia residents, the elderly who were mobile, but they had severe cognitive impairments, and trying to get them to consistently social distance, consistently wear a mask, consistently practice hand hygiene, those are the big three, right? That it becomes difficult. And one other issue that I would point out before we go on is the communication, that it's extraordinarily important, and both from a regulatory level, from an outside surveyor level, an outside surveyor perspective, that we have communication plans in place. How are we communicating with the families of your residents or your clients? How are you communicating with the clients or residents themselves? Because I think that when you read the news reports, you see that in a lot of cases, the residents didn't know what was going on in the facilities where they were living, and those facilities really sold themselves short by not making sure that the residents understood as best as they could what was going on and why they needed to do these types of things to protect themselves, whether it was moving people to different rooms, putting together a special floor for people who had the disease, having to be tested with a nasal swab up your nose every, once periodically, once, some of them as often as once a week. It's you really need to explain that and communicate that, and also to be able to communicate to those families and make sure that those residents and clients also have the ability to communicate with those families, because when we've got our buildings are all closed down, that becomes paramount, and making sure that we can just have that transparency and that openness between amongst those stakeholders compared to just your own workers stakeholders. So I think ideally, to be prepared, you would want some sort of system, whether it's the compliance assistant software that we used, or another software type, or even a very, depending on your size, you may be able to do with just a very rudimentary type system, whether it's just separate folders, a big book, whatever, what have you. But the same principles apply, that you look at the guidance and say, am I following the guidance? What do I have to show that I'm following the guidance? Are those documents up to snuff? And if it was to be looked at from an outsider. So that's my take. If there's any questions, I'd be happy to respond to them. If there's anything, either Joy or Jerry, that you'd like me to add, please do.
No, I think that was an excellent summary of what you experienced, Dana, and your team at the New Jewish Home. And the good news is that you got excellent results with the audit. That's because of all the prep work. But, I would like to, we have a nice list of folks here from the JAMA. I'm sure not everybody is shy. So what I'm interested in knowing, Dana's interested, and Julie, first of all, is anybody on this attending today, have you had an audit? If you did have an audit, do you know who it would come from? Just for clarification, are you relying on any kind of guidance like CDC or SAMHSA or some other guidance? Do you perceive that you will be audited at some point in time? And are you preparing now for that? So if anybody wants to raise their hand and make comments, that's fine. No pressure though. If no one wants to make comments, that's fine too. But this is being, kind of a sharing. Dana did a great job sharing his story. Does anybody else that's attending today have their story for their, NJAMA member agency, or, what maybe even larger organizations under NJAMA, like West Bergen? I see Karen's here. So we'll give you that opportunity at any point in time that we don't have to listen to me, and we'll share some information. I don't see any electronic Q&A yet, and I don't see anybody's hand raised. I'm sure you all know how to do that. You just have to click on the hand icon next to your name, and so we'll keep looking for that as we go. So I'll continue here. So Dana, we had talked about, and you had mentioned the team, and we're providing this list as a takeaway to everybody who's attending. Not that everybody has all these titles individually at their organization, but potentially folks that are fulfilling these kind of roles. And so Dana, you're the chief compliance officer. Do you see that role being the key role that is the team leader, pulls everybody together, coordinates, guidance?
No, I wouldn't say that. I think that we had certainly had a role to play in pulling together the different changes in regulatory, but our leadership really came from the medical staff. From our medical director was the one who led the group. And then we would break off. We had certain work groups to work on various, whether they're infection control issues or they're staffing issues. There were a lot of different, HR was a huge part of it, because we had to make sure that we could not only communicate with the staff so that they would come in and, not be afraid to come in, even by, when they tell the whole world to stay home. These are essential workers and they need to come in. We need their help. Even things like transportation alternatives. Okay, I don't feel comfortable taking a bus. Or I don't feel comfortable taking the subway. What do we need to do? How do we, what kind of masks are we going to get? So that's, I think a big one. Particularly in the beginning, where people didn't, there just wasn't enough information as to how, this is a highly contagious disease, yet, it's very specific in the forms of transmission. We've learned a lot more about, how we get infected, and what the signs are and all the different types of symptoms. So when in the beginning everybody was looking for a cough, well, a lot of people don't present with a cough. It turns out they could just have a runny nose, or they could have a fever without a cough, or they could have that whole loss of sense of smell. They realize was when that happens, you've got it. There's very little else that causes that. So we had to learn as we were going along, and making sure that we were able to communicate this stuff with staff and with families, and each other. I mean, there was quite a difference. One of the things we learned is, not everybody speaks CDC. So you could give them the guidance and they could look at it and go, I don't know what this means. And we would need to translate. Same thing with regulatory ease. I mean, a lot of what I've done over the past, what's it now, since, easily since March, is interpret state executive orders, state changes to rules, DOH guidance, see what's come down from CMS, what's come down from the president's task force. What do these waivers mean? Can I get a doctor from out of state who doesn't have a New York State license? Can I use a nurse from Connecticut? Can I use a physical therapist from Wyoming? All these things came up, and we had to look at it and see did it fit into the waivers that are there, and what was needed on our part in order to make use of those folks. Can we use home health aides as certified nursing assistants? Well, yes, you can. There was an executive order to that effect. There were just a lot of interpretive stuff that would help guide others in, creating those policies. I certainly read and rewrote and edited a whole lot of policies and procedures, reviewed a whole lot of audit material so people would develop an audit tool. It's great. Okay, so they went onto the floor and they looked at everybody's room and they checked out all the staff and they were all wearing the proper equipment and they were all washing their hands or using hand sanitizer properly. And that's great, absolutely great. There was no name, there's no place on the tool for the auditor's name, and there was no date on it. So we had to fine tune it. As soon as we saw that, we said, nope, that's got to change. We didn't, always have just piles and piles of screening documents. What are you going to do with them? Well, there's a lot of these kinds of decisions that are, behind the scenes that ultimately you're going to need to show. I mean, another thing I didn't even mention that comes up in anybody who's had any disease that has affected staff has usually gotten a visit or at least correspondence from OSHA, from the Department of Labor, because it's an occupational illness, it's considered. So what do you do for that? How do you be prepared for that? And it's a lot of the same materials that they want to see, but they also they take it up to the nth degree. So that's where you need like the facilities managers and stuff to say, okay, where are your safety data sheets for your hand wipes, and whatever solution you're using to mop the floors with, all that kind of stuff came up that you wouldn't expect. Things like food handling, things like, what kind of utensils are you using? All that came up because we had to, we couldn't have congregate dining anymore. So you had to, what changes and procedures have you done, and how do you work them for making sure that everybody's fed and that they're getting their meals, and are people who need help with their meals, so they're getting the help that they need, which is a very close one-on-one contact. So again, it's about having all the different stakeholders in place, and that the frontline staff and managers are adequately represented in that steering committee, because I could guarantee you that your chief medical officer has probably never spoken to your food service director. That's just the way life is. And they might need to have a conversation when it starts to making sure that things aren't cross-contaminated between units, and making sure that everybody understands the way infection control needs to work on all levels.
So, Dana, when you talk about all this, to me, it feels like a lifetime that we've been dealing with this pandemic, and it's only been 4 months or 5 months.
The longest 4 months in history.
Oh my God. Again, I feel like it's been here for like 10 years or something. That's just how, and then the question is, when is it going to go away, and they talk about coming back. Well, it hasn't gone away yet, so you can't come back if it doesn't go away, right? It was supposed to, calm down during the summer. That was not right. So who knows what's going to continue to happen here. But what healthcare organizations have accomplished in 4 months to address this problem of such magnitude has been so amazing to watch, even from the standpoint of organizations that needed to, switch to a lot of telecommuting. They got that done quick. Telehealth, they got that implemented quick. I was able to communicate. I had an uncle who was actually 95 COPD, came down with COVID, and he survived. Okay. He was in a nursing home, and they had FaceTime, and you can schedule FaceTime sessions, and I was able to see him. Couldn't go to see him obviously in the nursing home, but but he could see family and stuff like that. It was just a shift in things that needed to be done to, really just, cover so many things that had to be covered. So it's amazing, the results. And
Well, I think that's going to be, I think you just hit a very important point, Jerry, is that the next thing, what's the next thing? What do we have to deal with right now? Okay, so, we don't have any more cases in our nursing homes. That's great. But we're still a nursing home, and nursing homes are still off limits to visitors. How do we get the visitors? Well, they've come up with a plan on how you can have visitation. Once you have been free of cases in your facility, and I know they're doing a similar thing in New Jersey, at least for the nursing homes. I'm not sure how it is affecting other types of healthcare facilities, but you can have visiting as long as you can enforce social distancing, as long as you can, in New York State, the checklist that's what we're working on now. The checklist to prepare for visiting is huge. It is very complex, and you have to be able to show that you're in compliance with each of these steps in order to prepare to be able to have visitors, have your plan reviewed by the state, and then you can have it, in-person visitation. Right now we do window visits, and we do a lot of Zoom calls and that kind of stuff. But to have in-person visiting again, is great. But if we follow all these, if God forbid you get another case, when you open up and then a visitor brings the virus in again, they're going to be all over us and all over anybody else. And so you need to show that, hey, we followed all the recommendations, we followed all the guidances, it still happened, okay, then you're in a better place. If you could show that you did everything that you were supposed to do, then you're in a better place. And it is really hard. I mean, it's a heavy lift to follow those guidances, to the T. But
yeah,
to me, that is the biggest thing right now, because we're not, most of the New York, New Jersey area, we are not treating, there's very few active COVID cases, and everybody's, so the next step is, how do we prevent it from happening again?
Yep. Okay. So far, nobody's raising their hand, so we'll still continue a little bit here. And again, feel free to join in, anyone who's attending. So I want to, first of all, just show you that what you see here is the same platform for any of you who were aware that, Comply Assistant had the HIPAA program going, and we did get traction with member agencies. We did help with HIPAA. This is the same platform. The only difference is we filled it up with content in relation to COVID. So far, we have 8 guidances in there. AAFP is American Association of Family Physicians, CDC, et cetera. They need to use the one from CMS for nursing homes. If there's specific guidance for member agencies of NJAMA. We can add it quickly. Dana, you mentioned the New York State guidance on if you're opening up to visitors, that can be added.
Yep.
So it's very flexible. And of course, with NJAMA, our commitment is to provide tools and also help. So like with HIPAA, we did conduct assessments, and we can also help member agencies conduct COVID assessments and get your response plan in place. We could do that as well. And our commitment is to provide all these solutions and offerings at a very affordable price. We know that the budgets are very tight. We know that a lot of agencies rely on grants to do things, so we're very aware of that. And like Dana said, if you can get by with using a book, then use a book. Or if you have another approach utilizing, Excel, Word, maybe folders on networks, and email for communications, maybe Zoom meetings, whatever you're using, as long as you're using it and it's helping you and you feel organized and ready to be audited, then that's great. The one thing I can tell you about what we're offering is that everything is in one place, and it's all there. It's all organized, all structured, so that if you do get audited, you can just go to one place and be able to show the auditors everything you've done, and we can help you get there. So for next steps, for one thing is that you can submit questions after the fact. We didn't get any today, so we're not going to be documenting any in here. You can also attend a full demo, which could be about 20 to 30 minutes of the solution. Anybody who wants to can just email me, and it'll take, we'd say 45 minutes, but we could keep it to 20 to 30 if that's preferable, to give you a good sense of what it's all about. And again, feel free to reach out to me. There's my email address again, and there's Dana's if you have any questions after today. So first of all, I think, the summary from Dana from a nursing home in a hotspot in New York City was a tremendous summary. And again, in a 4-month time frame, what they have accomplished over there. I'm sure that all of you are accomplishing a lot too in this regard. And anytime you want to, have a discussion about that, we're open to talking with you, even if it's just to tell us your story about how, what's going on at your organization. So with that, I will say that I don't see any questions, so I think we're good. Julie, did you want to make a closing remark?
No, I'm good. If anybody has any questions or wants the copy of the link, well, we're going to forward it to everybody anyway. But if anybody has questions, they could shoot me an email, and I'll get answers the best way I can.
Right.
But,
and I can tell you that our goal is to make it very affordable. So if you like the tool and you think it's going to help your organization, if you think you need it, then we will make it work from a budgetary standpoint. That's our commitment to NJAMA. Okay. So thanks everyone. Hope you have a great rest of the day, and thanks for your time today. Thank you, Dana.
Thank you for the
And
opportunity to share.
Julie, thanks for putting it all together.
oh, thank you, everybody.
All right.